like to share with you what we have achieved so far and also what are the future challenges. No need to say that Jim Kim, the World Bank Group president, has said quite highly about the Thai UC systems. And these are the three outlines. I add at the end on the current challenges and the future responses. Start with the background. Thailand is an upper middle income country, which high level of health achievement in terms of life expectancies and mortality outcomes. Universal health coverage was achieved by 2002 with a comprehensive package of health services and almost zero co-payment at point of service. Health spending is less than 5% of GDP, and our pocket payment is quite low, 11.3% of the total spending, where the public spending on health was 80% of total health expenditure. It was increased from 56% in 2001 prior to USC. So it is self-evident that government has strong intention investing in health of the people. Declining child mortality trend was notable. It was on par with high-income non-OECD countries and slightly lower than the upper middle-income peers. We have achieved 12.6 per 1,000 live births in 2015. Both X and Y axes are the relative performance of child mortalities to the predicted child deaths from the regression line. The left upper quadrant show country, the left lower quadrant show country having above average performance as their child mortality is lower than the predicted value. So the predicted value is a regression value, and you subtract the observed value and the predicted value. The minus is the best perform compared to the plus. So we can classify the whole countries in the world into four quadrants. The right upper quadrant is the poorer perform in terms of their income per capita and total health spending. So in the X and Y axis. Next slide is on maternal mortality ratio. It is relatively above average perform in Thailand, which is Thailand is located in the lower left quadrant. So that means MMR is performed compared to the total health expenditure spent and also the economic capacity of the country. The previous two slides, which is under death, under 5 mortality and maternal mortality ratio, are the health outcome indicators. The next two slides is the resource input in terms of hospital beds. In this slide, similar performance assessment was conducted. Hospital beds in Thailand is relatively below the average. So that means we are located in the left lower quadrant. So that means our health resource as measured by hospital beds in relation to total health expenditure and gross national income is relatively lower than the expected value from the regression line from the global countries. Another slide is health resource input in terms of health workforce per 1,000 population in relation to total health expenditure and gross national income per capita. Similar analysis using World Development Indicators dataset. We see that Thailand located in the left lower quadrant, which is below the regression line average. There's some minor correction. If you would please make correction on slides, hospital beds. On the left lower quadrant there, on the y-axis, it must be below average, not above average here. Similar to the next slide, which is health workforce per 1,000 population. So on the y-axis, please make correction that it should be on the left lower quadrant should be below average, and vice versa, above average on the upper part, left upper quadrant. Next slide is the out-of-pocket payment as percent of total health expenditure trends between 1995 and 2013. As a result of UC scheme, which was introduced in 2002, the out-of-pocket payment has substantially reduced from around 30% of total health expenditure to less than 11.3% of THE. This is much lower than the much lower than the high-income non-OECD country and on par with high-income OECD peers. So this is the lower the OP as percent of total spending, the lower catastrophic expenditure incidents and medical impoverishment. So subsequent empirical evidence also confirm that the incidence of medical impoverishment is much lower and very good performed. That's why Jim Kim has paid a very high tribute to the performance of Thai UC system. Not much so by policymaker in Thailand, which may be mimicked by myth and misunderstanding, misinterpretation, even at the Prime Minister level, that our system is frail, has some problems. So outsiders' viewpoint and insider viewpoint quite different. This is a gap of policy communication that we must do something to improve the situation, and this is one of the best performed, not less than the Australian colleague here. Fiscal space in this slide. Fiscal space in Thailand is on par with upper middle income countries, but lower than high income OECD countries. Government revenue was around 20% of GDP. This is quite conservative without change in the last 20 years. Another slide on fiscal space for health. That means health expenditure as percent of government expenditure. Fiscal space for health is measured by GGHE, General Government Health Expenditure, as percent of GGE, General Government Expenditure, in 2013, and compare the whole, every countries in the world. We are above average of the regression line compared with countries having similar GDP per capita. It's really a long march between 1975 and 2002 when Thailand has achieved USC. We first launched free care for the poor in 1975 when the Thai GNI per capita was merely less than $400. And we achieved USC by 2002 when the GNI was less than $1,900. And it is at the bottom of economic crisis, which was not fully recovered yet from the 1997 Asian economic crisis. Today we have three schemes: government employee scheme, the private sector employee scheme, and the rest of population, which is the UC scheme, financed by general taxation. Similar to the Australian, you have Medicare levies, which is 1.5% of the assessed income, personal income tax. We use general taxation as a main source of financing USC. What are the USC achievements? Despite political conflicts in the last 14 years, UCS flourished across 8 rival governments, 7 prime ministers and 13 health ministers. Empirical evidence has shown positive outcomes of UC scheme in all dimensions: pro-poor utilization, pro-poor benefit incidence, minimize medical impoverishment, gaining efficiency and cost containment, which is we use capitation for outpatient services, and global budget plus DRG for inpatient care, similar to what Australia has presented. And we have a bit one step before Australia, because we introduced capitation, whereby Australia has remained struggle with fee-for-service, although you have a cap on the fee-for-service. In terms of poverty prevention, we measure the level of catastrophic health spending. We use more than 10% of household spending, and compare before and after UC scheme in 2002. The incidence of catastrophic spending as measured by this measurement has gradually reduced, and more among the poorest quintile than the rich quintile. Counterfactual scenario in the dotted line: if there were no UC scheme, there would be this amount of household impoverished from medical bills on the dotted upper line. The solid line is the observed data from household surveys by NSO, National Statistics Office. The gaps between dotted and solid line is the net number of households prevented from being impoverished as a result of medical bills. In terms of service utilization, use rate has improved both OP and IP, outpatient, inpatient. IHPP worked with NSO to monitor through national surveys the unmet healthcare needs, for which we apply standard OECD standard questionnaire survey. The unmet need was extremely low, on par with OECD countries, and this was published in BMC Public Health in 2012. Which health system characteristic contribute to such a good performance UC scheme? District health system is the skeleton of Thai health system and contribute to these favorable outcomes. It has a catchment area of 2,000 to 5,000 for health centers, and a district hospital with 30 to 80 beds for a catchment population of 30 to 80,000 catchment population. District health system is functioning due to mandatory rural services by all new graduate medical nurse, dentist, and pharmacist, which was introduced since 1972. And Thailand did not rely on any single expat doctor and nurses. So we are self-reliant on local production training of qualified doctor and nurses. whereby still OECD country very much rely on expat, international recruit doctor and nurses. And Indian doctor is the highest share in OECD country, and Filipino nurse is top one in OECD countries. As a result, we note chief of services utilization from tertiary care hospital dominance in 1977 to primary care dominance in 2010. This is a major achievement. The UCC scheme contract district health system as a major contractor providers, for example, capitation, which later was adjusted for outpatient services and with primary care fund holder functions. District health system is a hub for pro-poor outcome. District health system refer to health center and district hospital. It is a close to client service. It's a major hub in translating UCS policy into a pro-poor utilization as measured by concentration index. The minus sign demonstrates utilization is in favor of the poor, and the plus sign is vice versa. For example, in provincial hospital, slightly pro-rich, and the overall on the last column is slightly pro-poor. Private hospital is plus is a plus sign of concentration index. It is a pro-rich outcome in terms of utilization. So what are the contributing factors? First and foremost is a continued political commitment and support in terms of funding support. Budget used to subsidize UC scheme increased from 1,200 baht per capita in 2002 to around 3,000 baht in 2014, which was almost 3 times increase. This is a result of increased use rate, expansion of high cost, but effective intervention with HTA assessment, health assessment requirements for new intervention to be covered in the benefit package. And cost increase in particular for due to 4% salary increase and 2% medical inflation. The merit of close-end payment applied by UC scheme is cost containment. Capitation is used to pay OP services. Global budget and DRG was used to pay inpatient services. It sent a strong signal to doctors and hospitals towards efficiency to keep the margin and live with the global budget and DRG and live with the capitation. The downside is the potential under provision of services. It was fully addressed by complaint management, accreditation, and audits by NHSO. Benefit package since 2002 was comprehensive, where negative list is applied with a small list of exclusion. Renal replacement therapy is exceptional. It is cost ineffective, but it is catastrophic and impoverished to the household. Dialysis was included in 2006 due to ethical and equity consideration. When HTA was fully applied, later phase in 2008, using local capacity on HTA, notably by HITAP, Health Intervention and Technical Assessment Program. There is a cascade level of coverage decision. First and foremost is cost effectiveness, followed by budget impact, and finally health system readiness to implement the new intervention. If cost effective plus low budget impact, decision is almost always yes. For example, lumiwadin, lamivudin, and the treatment of lupus nephritis. If it is cost saving and low budget impact but limited capacity to provide services, decision is no, unless the service has capacity to implement, for example, dental implant. Monopolistic purchasing, where a single buyer purchases goods and services from multiple sellers, has a high potential for cost saving given actual quality. NHSO managing UC scheme had demonstrated its capacity in negotiating price down with a total cost saving of $188 million during the period of 2009 and 2012, and this will provide more services to the patients. In conclusion, UC scheme was implemented in the context of mature, extensive geographical coverage of functioning supply side as a result of 3 decades of health infrastructure investment by the successive governments since 1970. Second conclusion, district health system facilitate access and is a main hub of a pro-poor outcomes. Third, cross-end payment contribute to efficiency and cost containment. And finally, a comprehensive package result in high level of financial risk protection. So Thailand has proved the world a concept of it is feasible to implement a UC scheme with a favorable outcome. I'd like to end with saying by UN Secretary General Ban Ki-moon, you don't have to wait to be rich to provide these health services for the people. And we are not rich enough, we cannot afford fee-for service, for which the government employee scheme is still applying, and there is no trend of positive reforms, even by this current government. And we know that inefficiency in the CS/MBS is a major pain, and it provides a fertile soil for conflict of interest in supply-induced demand, boost and prescribe more medicine, more non-essential drugs, whereby we know very well that pharmaceutical industry and doctors work closely hand in gloves, and the only provider payment that can break this bizarre behavior, I would say. So this is a pain. Finally, the challenge is very clear. We know this harmonization across the 3 schemes, still some inequity across the 3 public insurance schemes in terms of government subsidies, provider payment method, urbanizations. I listened carefully to our colleague presentation, and we learned a lot, and primary care is the cornerstone of Australian health system. You start to have innovation on step down services, intermediate care, I would say. Most of the chronic care still occupy acute care hospital beds. Still, we have to a lot of ongoing investigation and reforms. Most critical issue is how we translate this evidence to a right policy decision. Thank you so much.
Thank you very much, Dr. Biro, for the lecture. And if you have any questions or idea and would like to share with us, please don't keep it inside, just share with us.
Yes, we would like to encourage you all to reflect what you think and what you like to share with your peer. And because Dr. Willow is still here, so we can ask him and share idea with him. He's very kind to us because yesterday he was in Hanoi, and just specifically come here for us. And tomorrow he has to fly to World Health Organization.
I'm afraid they are a bit hungry already, so they don't have any question at the moment.
เพลินพิษพงษ์ปริญญากุล from the College of public health administration here. For two speakers, the great speaker that I learned some, I learned a lot of how to drive, how to improve the quality of life of the people in Thai. And for the point that I would like to know more is Dr. David said about the new model of hospital in home. And also for Dr. Birod, I'm interested about the primary care that I think both of this idea is can solve the problem or drive the policy of Ministry of Public Health now to expand the primary care cluster. Yeah, and just I would like to know more about the new model from Australia, and also for the primary care cluster can solve the problem of the health of people in the future. Thank you.
So you ask for their viewpoint.
Both.
Their viewpoint.
We do not call hospital in home. We are a little bit allergic. The term hospital is most curative. But we have home visit, and this family care team will look after the elderly people, the frail elderly who cannot access to services. And bladder care, folate care, bedsore care, etc. So all these are in the policy pipeline for scaling up. It's part of the district health system. So family care team is consisting of doctor, nurse, and other paramedics, mostly based on outreach, home outreach clinics, so home outreach services. Perhaps Dr. Somsak can clarify more the situation of scaling up.
Thank you, Dr. Virod. And David, would you like to respond?
Another name was Health Hub, and at a meeting last week with our community council, we used the name Hospital in the Home and Health Hub, and our community thought the names were pretty ordinary, and we should think of a new name. But essentially, we're picking up on other people's ideas and trying to change practice and where care is provided. That's the important part. And so the health home that's being established, they're pilots, and they'll probably develop in different ways. But they'll certainly involve a multidisciplinary team of people working in a general practice together to deliver better care and better outcomes for people who might otherwise end up in hospital. So that's the intention. The Minister only announced it yesterday, and that we've been selected as one of the pilots, and we'll identify ways of delivering that better care. So it's early days, but it's obvious from the care that's provided both in the acute care sector and the primary health care sector that we could do a lot better than what we're doing with the money we've got. And it's the structural differences in our system, your system that either help us do that or complicate it. So it's, I talked about the government gradually taking control, but I think what's happening now is there's a gradual change in health reform policy that won't provide solutions, but will provide opportunities to do things better, and we'll build on that. So that's a significant change from just saying this is what we're going to have and this is what we're going to do and this will improve healthcare. I think we're piloting, we're looking at the step models of care. When we looked at the medical atlas for Australia, particularly in the mental health area, we're just prescribing far too much medication to people with mental illness and not providing any supportive or appropriate care around that medication. GPs don't have time to spend with them. They give them the medication, they go away. So that's a cost and an ineffective delivery of care to a fairly significant group. So what we're trying to do is, with the clinicians, with the communities, develop a model that will cut across that and provide better level of care at the area and need they need it, reduce the reliance on medication and provide better engagement and support. So it's like the aged with their ulcers. Our problem is that in the aged care facilities, if they go to an acute care sector with a problem, they often come out worse off than better off from the acute care sector because of their frailty and because of the way the acute care system works. So we're now looking at having nurses that support patients in aged care centres so they don't go to the acute care sector and we get a better outcome. So there's no one answer, but there's a recognition that despite the fact that we've got a very good health system, there are a lot of things we could do better. And the good thing about what the government's doing is they're piloting models and giving primary healthcare networks and clinicians opportunities to experiment, collaborate and do things differently. Okay? So we're out there now talking to our clinicians and communities saying, if you've got a good idea, come and tell us about it. We'll give you some seeding money. We'll let you trial a model that might help improve, in addition to our big job of commissioning services. So it's about innovation, it's about change, but it's about a consistent evidence-based approach to try and deliver better care over a period of time. And if the government will leave the structure alone for a while, we might have a chance of doing it. Thank you.
Thank you, Professor David. And I hope you got the answer from our professors. I think we have some more questions, right? Oh, Dr. Supramit.
I raised my hand because I was afraid no one would. And the service has already been made. But anyway, as you provided me an opportunity, I just wanted to ask Professor David one question. I've learned your lecture with great interest, and a lot of that is mind-boggling for me, because the system being developed in Australia is much different from what we've learned in our own experience here. Part of my job, probably major part of my job, is dealt with epidemiology, public health and disease prevention and control. I'm curious how those part of public health is being addressed in your public health network. Basic things like disease surveillance, prevention, control, public health emergency management. It sounded like that is a different part of the service that might be taken care of by someone else. But I believe your system will be doing your job in close association with that part of the public health service. Can you please give us some deliberation?
Thank you very much for the questions.
Thank you.
Very good question. Public health and population health in Australia at the national level deals with borders and quarantine and national disasters, so that's their remit. At the state level, it's traditionally been part of the state health department in each state, so the local health districts that run the hospitals all have a public health unit, and they do all the traditional public health measures and surveillance and monitoring and regulation, inspection, all that type of thing. So that exists and has existed for a long time and is being done very effectively. So regional people in the local health district, state coordination of that, national coordination, but they exist within the health districts. When we were set up, we also had a remit about population health and public health, but ours is more about planning and how we use the skills and the data and the epidemiology of the population health and public health people in providing better health outcomes overall. So where I work in the PHN, We have some people working on population health, only a few, small number, but we have a big public health unit down the road in the health district. The two of them work together, and we use the data in planning primary health care services and in determining priorities. So that's where we're getting this stuff about demography, morbidity, mortality, disease rates across by local government area. It was all coming through that public health, population health, epidemiology input from the health district and from our small couple of people working with them and with others. So we won't be replicating the traditional functional role. That'll be left where it is, but we'll be part of it in terms of planning primary health care services.
I have Dr. Patharawalai from Sri Lanka Medical School, Mahidol University. Please.
May I ask one question for Ajahn Suwit?
Ajahn
sorry. We talk a lot about the co-payment for the sustainable of USC. Do you think co-payment is essential? And what should it be?
This is a political question. And in the middle of negotiation, supersede is the way, no? Because he may introduce under Sonocho umbrella, which is appointed by a working group appointed by Prayut Chan Ocha, chaired by Pirom. We call Pirom working group there for task force. Co-payment can be essential if there is a need to send signal on to the consumer for unnecessary use of services. Co-payment has no objective to mobilize adequate funding. So this is the principle of co-pay. Send a signal that this service is not zero cost. You have to pay something. Second, adverse moral hazard on the consumer, on the patient side is so minimum under the cost and payment, because moral hazard by doctor is stronger than moral hazard by the patient in the context of fee for service. Moral hazard, Philippines Field Health Corporation, China, Vietnam, all introduce or apply fee for service. Then moral hazard come from the provider side. You need more investigation, you need more medicine, you need more diagnostic, you need more admissions, because I gain more money from providing more services. Therefore, co-payment under fee for service is harmful to the patient. You cannot minimize the catastrophic spending. You cannot minimize the social goal of impoverishment, because our pocket payment is shouldered by the patient. In the context of majority payment of Thailand, which is close-end, provider did not have moral hazard. Therefore, in a asymmetry information system in the healthcare market, that doctor knows more than the patient, and if he behave well, because if he does not have moral hazard, because of the payment is close-end, I cannot generate more services. Therefore, he will discourage unnecessary use by the patient. The current cost increased by Thailand up to 3,000 something baht per capita per year. Budget is the result of one is demographic change, second is the technology advancement, third is the higher benefit package, higher cost, high cost services being included in the benefit package, and also the salary increase every year 6-7%. Therefore, it's a natural increase. One way is to improve the fiscal space for health. Medicare levy 1%. in your personal income tax. But guess what? How many our personal income tax payer? Less than 4 million income tax payer. Therefore, most of the tax come from a general tax, including VAT, value added tax. So it's still not feasible politically, even in the future government to introduce Medicare levy. So that's one solution, which is politically not so feasible. But if you want to introduce co-payment, you have to introduce across the board to ensure equity. Not only UC scheme member who pay the co-pay. What about CSMS, which is General Tax Finance Scheme? What about the social insurance? Therefore, the PROM working group must not divide the society, must not destroy the current achievement of high level of financial risk protection today. Therefore, this is a political question. Thank you for your difficult question.
Thank you very much.